afternoon, everyone. I hope you guys have all had a great lunch and a good day so far. We're going to start shifting gears now, and we're going to move into obesity and start talking about MASLD and a whole bunch of other fun GI topics this afternoon. So I want to introduce Dr. Christian Horn. I had the pleasure of working with Dr. Horn at Brooke Army Medical Center for several years, where he was the chief of hepatology there now, and he's moved on to greener pastures, literally, at Madigan Army Center, Medical Center, and is now the chief of hepatology there. So I'll turn over the mic to him. Thanks.
Well, thank you all. Thank you all for having me. Can you hear me? Yes. All right. Is it actually coming out over the loudspeakers or no? All right, that's fine. I can project my voice. I'm going to be talking about two different topics that are actually relatively related. So we're going to start with talking about obesity management, and then we're going to go into MASLD and then MASH. So unfortunately, you're going to have to listen to me talk for an hour or so I apologize. This is what we're going to talk about. We're going to talk about the definition of obesity, talk about the epidemiology, some pathophysiology, diagnosis, how to make the diagnosis, complications of obesity, why do we care about it, and then we'll also talk about what options are there for treatment. So this is where we'll get into a lot of those weight loss medications that are really starting to get big right now, okay? So I hate reading off slides. I'm going to try not to do that right now for most of this talk, but this one is really important, okay? So this is the one I am going to read word for word off the slide just so we can all be on the same page. According to the Obesity Medicine Association, obesity is defined as a chronic, progressive, relapsing, and treatable multifactorial disease, neurobehavioral disease, wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. Now, I stress this because to me, this is one of the things that isn't really well known about obesity as a disease, right? It is chronic, it is relapsing, and it is progressive, okay? So that is something as providers we need to be aware of when we're treating patients with obesity, knowing that because the disease is getting worse, it's not necessarily their fault because the disease progresses, the disease relapses, okay? As far as epidemiology is concerned, so unfortunately it's common and it's getting more common, okay? So if you were to look at this study from 2017 to 2018, 42% of adults over the age of 20%, or over the age of 20 have obesity, okay? This is worse compared to the last NHANES study that was done from 1999 to 2014 when it was about 35%, okay? Even in adolescence, it's getting up there. So you're talking about youths that are less than 20 years of age. The prevalence of obesity is approaching 20% of adolescents or youths, okay? So this is something that's starting young and it's progressing into adulthood and it's getting worse. It's worse in non-Hispanic blacks, and it's also worse in Hispanics. Seems to be a little bit lower in non-Hispanic Asian populations. It's projected that by 2030, 50% of the US population is going to have obesity, and then 25% is going to have severe obesity, which is a BMI over 35, excuse me. So it's going to be something you're probably going to see, especially in this area. It's very common in the South and the Southeast. So we make the diagnosis of obesity using different measures. So these are three different options. So you have your body mass index, which is probably what everyone knows about. That's a classic way that we diagnose it. You take your weight divided by height in meters squared. They'll pump out what your BMI is. Everyone's pretty familiar with that. We get the height and weight every single time we see patients in clinic, so we can make that very easy diagnosis, right? It correlates pretty well with adverse outcomes as well. So physical forces, abnormal metabolism, all that kind of stuff, it correlates pretty well. Then you have percent body fat or body composition. So this one is actually telling you how much of the body is composed of fat tissue or fat mass as opposed to lean mass, et cetera, et cetera. So this one is good because it's telling you specifically how much fat there is in the body. Unfortunately, it doesn't really correlate, or we haven't been able to correlate it so well yet with adverse outcomes. And then waist circumference, pretty straightforward, pretty easy to use. There are some nuances in the techniques on how you do waist circumference. So if you're interested in seeing that, you want to look at specifically how you do it. Usually you do it at the top of the ASIS, and you want it to be around the abdomen, but not like super tight and like squeezing in on that. There's breath work that goes along with it. Do you take it on the inhale, the exhale? So there's certain things that go along with taking the waist circumference. It's good, it correlates well with adverse outcomes up until a BMI of 35. After that point, it doesn't correlate as well as the BMI does. So this is the cutoffs that we're going to use when it comes to different diagnoses of obesity, right? So if you're using a BMI cutoff, 18.5 to 24.9, normal weights. Anything above a BMI of 25 to about 30 is going to be considered overweight, and anything with a BMI over 30 is considered obese. And then we can classify this into different classifications. So you have class 1, 2, and 3, class 1, 30 to 35, class 2, 35 to 40, and then anything over 40 would be class 3 obesity. As far as percent body fat is concerned, it's going to differ depending on gender, okay? So women usually are they have a little bit more body fat on them, so 30 to 34% is going to be pre-obesity or overweight. Anything above 35% is considered obese. And then for men, it's a little bit lower, so 25 to 30 is going to be pre-obesity, and then anything over 30 is going to be obese. Abdominal adiposity, so the waist circumference, this is telling you what obesity cutoffs are. It's not overweight. Okay, so 35. Yes, this is obesity. 35 inches or 88 centimeters is technically obese, and then for men, 40 inches and 102 centimeters. I put these diagnoses, the ICD codes in here as well, because when you're coding and seeing patients in clinic, you can actually code and get more RVUs for diagnosing obesity and all that kind of stuff. So that's all up there for you guys to review later on. What about body composition? So this is going to be the one that's kind of the most in-depth and the most difficult to do, because you're probably going to have to send them to another location to have that done. So body composition can be done in multiple different ways. So the gold standard is to do a DEXA scan. The DEXA, just similar like we do bone density scans, you can do a DEXA scan to help you determine what body composition is. That's the gold standard. It's hard, it's expensive, so we don't always use it. So you can do stuff like calipers, bod pod, you can do bioelectrical impedance. Each one of these has something that's positive to it and it has negatives to it. So like the bioelectrical impedance and the bod pod, those are both dependent on your fluid status. So did you eat or drink beforehand? Did you exercise before you got this done? So you have very specific instructions that you have to follow in order to get these actual measurements correct, okay? When you do these measurements, what you're going to get is a number of different body compartments. So your total body mass is going to be your fat mass, your bone density, and then your lean muscle mass or your lean mass. Your fat-free mass is basically your mass minus all fat in the body, okay? Which includes non-essential storage fat, and it includes essential fat, like you would see around nerves, like myelin and all that kind of stuff. Your lean body mass is basically your muscles, your tendons, your essential fats. Those are all the stuff that isn't like storing extra calories. Your fat mass is the non-essential storage adipose tissue. Okay, so that's what we're looking for. That's what we want to get. That's how we determine what your percent body fat is. So you take your fat mass divided by your total body mass minus the bone density, and that will give you your percent body fat. So where does this come from? Let's get into a little bit of the pathophys. It seems like it's a very simple equation of plus intake and then minus coming out, right? But it's a little bit more nuanced than just that. So when you're talking about intake, it's basically whatever you're consuming, okay? So that's your caloric intake. That's going to be what goes on the positive side of the equation. On the negative side of the equation, the output is going to be made up of multiple different parameters, multiple different components. The first one is your resting energy expenditure, or your basal metabolic rate. This is everything that your body does when you're at rest or when you're laying down, like metabolizing, synthesizing proteins, et cetera, et cetera. The stuff that you really don't think that you're doing or that you are doing on a daily basis, that's what your basal metabolic rate is. When you get to your non-resting energy expenditure, it's multiple different components, right? So it's exercise activity thermogenesis, when you actually plan exercise activity. You have what's called NEAT, your non-exercise activity thermogenesis, and you have the thermic effect of food. We'll get into NEAT in a couple of slides, but the thermic effect of food is dependent on what you're eating. The more complex and the more difficult it is to digest, the more you're going to have that used to burn calories, okay? So when you're looking at your total daily energy expenditure, you can see your basal metabolic rate is by far and away the highest component to this, right? Your NEAT is actually the second highest component, and it's also the most variable component of all of these. And then exercise activity thermogenesis is really a small portion of it, but it doesn't mean that you shouldn't be exercising. So a little more about pathophysiology. So once again, you have the intake side of it, which is going to weigh the scale down on one side, and you're going to have this what's called orexigenic pathway. So this is your hunger pathway. When you're getting into the neurobiology, it's going to start with hormones that stimulate hunger. The main one is ghrelin, which comes from the stomach and the proximal small intestines. The ghrelin goes to the arcuate nucleus within the hypothalamus, and it stimulates these neuropeptide Y and agouti-related peptide neurons in the arcuate nucleus. Okay? That goes to the lateral hypothalamus, and it stimulates the orexigenic pathway. I know it's a lot of neurobiology there. I'll show you another slide that might make it a little bit easier to understand. On the flip side of it, we're going to have the basal metabolic rate, your NEAT, your thermic effective food, and your energy, exercise activity thermogenesis. That's going to be your anorexigenic pathway. This is your pathway that you're getting rid of extra energy. So from the anorexigenic pathway, you have multiple different hormones that stimulate it. So GLP, we probably have all heard of GLP. You have leptin, insulin. Leptin comes from the adipose tissue, insulin from the pancreas, GLP comes from the distal small intestine and the colon. That will go to the hypothalamus as well, to the arcuate nucleus, but it stimulates your POMC-CART neurons, which are different neurons in that same little area in the brain. Goes to the paraventricular nucleus, also within the hypothalamus, and it stimulates the anorexigenic pathway, right? So remember, anorexigenic pathway is like anorexia. You're not going to eat as much. That's how you can remember orexigenic versus anorexigenic. This is what I was talking about. So this is kind of hopefully a simplified version of that neurohormonal pathway. You can see where all these hormones are starting from outside of the brain. They're going to the hypothalamus, to the arcuate nucleus. And while they're stimulating one pathway, they're also inhibiting the other pathway. So if you're stimulating the orexigenic, you're also going to be inhibiting the anorexigenic pathways. And then different neurons to the lateral hypothalamus and the paraventricular nucleus stimulating different hunger or not hunger signals. So why do we care? Because there are complications that come from having too much adipose tissue on you, right? So there's two major categories of these complications. You have the what's called adiposity, or sick fat disease. And so this is a derangement of the hormones of the immune system that leads to complications like high blood pressure, high glucose, diabetes, muscle MASH. So that's where that comes from, okay? On the flip side, you have what's called the fat mass disease. And this is basically the compression of different tissues from the extra adipose tissue, okay? So you have stress on weight-bearing joints causing arthritis. You have immobility because of too much adipose tissue. Tissue compression causing sleep apnea, GERD, heart failure, and then tissue friction causing intertrigo, right? These are the complications that people develop as a result of obesity. Now, not everyone's going to develop complications at the same rate, right? So let's look into this just a little bit. In the body, there's a number of safe storage spaces for fat, okay? I say safe in quotations because it's relatively safe. It's not 100% safe. But there's certain areas where the body is designed to store extra calories. In the subcutaneous adipose tissue in the abdomen, in the thighs, and in the gluteal region, okay? Those are all quote-unquote safe storage areas. At some point, though, if you continue to consume calories and get extra energy into your body, you're going to exceed the body's capacity to hold on to extra calories in those safe storage spaces, okay? And then you're going to overflow, just like a bathtub, okay? So at some point, the bathtub is going to overflow. Now, here's where it's different between person to person. Everyone has different sized bathtubs, okay? So some people of Asian ancestry might have a smaller bathtub, and so they're going to overflow at a lower BMI. Some people of African ancestry might have a larger bathtub, and so they're able to hold on to more calories before it overflows and causes complications, okay? So once your bathtub, whatever your size bathtub is, starts to overflow, it goes to different areas of the body. So those calories have to go somewhere. Once it overflows out of your safe storage, then it goes to the liver. Or then it goes to the pancreas, and it goes to the hearts, and it deposits in these organs, and it causes complications from fat or extra adipose tissue deposition in these organs. So in the liver, you have muscle MASH. In the pancreas, you can get diabetes, pancreatic insufficiency. In the heart, you can get heart failure. You can get coronary artery disease. You can get arrhythmias. In the blood vessels, it can cause hypertension. If it goes around the blood vessels, it can compress those and cause hypertension. It can get into the muscles and cause muscle dysfunction, and then get into the kidneys and cause abnormal signaling in the kidneys, okay? So this is how that happens. You overwhelm the safe storage space, and then it goes and it causes dysfunction in all these other organs. Any questions about that? Everyone understand that? Excellent. So let's treat this. Let's talk about the things that we can do to treat fatty liver disease, talk about things we can treat pancreas problems, all that kind of stuff, right? So we have lifestyle modifications, which is the cornerstone of therapy for people with obesity. It has to be part of your plan, okay? You can't neglect that. The anti-obesity medications, we'll spend a good time talking about that, and then I'll touch briefly on the endoscopic, bariatric, and metabolic procedures, as well as bariatric surgery. Now, you're probably gonna see some similarities between some of these slides and on the next presentation because the treatment is similar. All right, so when it comes to nutrition, there's a lot of different advice out there, but the bottom line is any nutrition program that you have for people should always come with at least a moderate caloric reduction, okay? So what you're gonna tell a patient is count how many calories you're taking a day and then decrease it by about 500 to 1,000 calories per day. That has to almost always go with any sort of dietary or nutrition recommendations. Some things that the Obesity Medicine Association talks about is up here on this list. So you want to limit those really highly processed foods, the things that we call cakes, cookies, pies, all that kind of stuff. You want to try to limit that as much as possible. Limit saturated fats. You want to limit simple carbohydrates, right? So simple sugars, all that kind of stuff. If you're going to recommend any artificial sweeteners, you want to limit your sucrose and saccharin, and you want to recommend those other ones, okay? Cholesterol can also make cardiovascular disease worse, so if a patient already has cardiovascular disease, they want to limit that. Completely avoid energy-dense food and beverages, like sodas, juices, alcohol a lot of the times, and then you want to avoid trans fats. It's easier to avoid trans fats because mostly they're banned in this country now. And you want to encourage whole foods. You want to encourage vegetables, fruits. You want to encourage eating meat that has high levels of unsaturated and polyunsaturated fats, like fish and things like that. Lean meats, like chicken if you can. And then no sugar added daily, minimally processed whole foods. As far as like the carbohydrates are concerned, carbohydrates are not all bad, but you want to recommend what's called complex carbohydrates, or things that have a low glycemic index. Does anyone know what glycemic index is? Heard of the term before? So what glycemic index means is something that has a high glycemic index food means it's going to stimulate the blood sugar to go way up, right? Something that's a low glycemic index food is going to cause a very mild elevation of the blood sugar, okay? So when you're talking about glycemic index foods, you want a low glycemic index food that's usually going to be a complex carbohydrate or high in fiber sort of thing. There's plenty of different dietary patterns that you can recommend to patients, right? And I'm not going to go through all of this right now, but once again, you want to have some sort of modest caloric restriction with it. The very low and low calorie diets are kind of an extreme version of that. And so basically what that's saying is you're going to have these low calorie diets, and we're not going to restrict what you're eating as long as you're following how many calories you're supposed to be taking in per day. There really is no difference in the long term between a carbohydrate restricted diet and a fat restricted diet. So if you look at the outcomes at 6 months, it's equivalent. It might be a little bit different earlier on, but at the 6-month mark, there's no difference between low fat and low carb diets. That being said, if your patient has diabetes, you should probably encourage that low carb diet because that's going to help with the blood sugar. All these other ones, I'm not going to go through them all. The one thing I will say is I always follow a Mediterranean diet or recommend a Mediterranean diet because it helps with mast cell to MASH, and I treat a lot of mast cell to MASH patients, and it also helps with cardiovascular disease. As far as fasting is concerned, this is a big hot button thing. There's no added benefit of fasting outside of the fact that patients are taking in less calories, right? So there's no magic thing about fasting that stimulates anything else in the body. Basically, you're fasting because you're taking, or it works because you're taking in less calories. The most effective diet is one that is safe and patients are going to follow. So you need to have a discussion with patients about this and make sure that they are on board with whatever diet you're recommending them. Activity, so this is energy, exercise activity thermogenesis. You want to try to optimize, aerobic activity, 150 minutes to 300 minutes per week. So that's usually about 30 minutes 5 times a week. Not that hard, moderate physical activity. If you want to go more intense, vigorous activity, you can drop that down to 75 to 150 minutes per week. The more activity you do, the more it's going to be effective. Resistance training, usually about 2 to 3 times per week, 45 minutes on average. You want to build muscle because muscle is actually one of the things that will increase the basic metabolic rate. When you lose weight, your basic metabolic rate is actually going to go down because your basic metabolic rate is somewhat related to your body mass. The higher you are, the higher your basic metabolic rate, right? But if you're increasing muscle mass at the same time that you're losing fat mass, it's going to kind of offset each other. So you want to encourage this because the more muscle, the more likely they're going to dispose of energy better and safer. The non-exercise activity thermogenesis. This is everything that you're doing that is not exercise activity. So me nervously pacing back and forth in front of you on the stage right now is non-exercise activity thermogenesis. Walking up the stairs or parking further away from wherever you're going. So when you're going into the hospital or the clinic or wherever you're working, if you park at the back of the parking lot and have to walk all the way into work, you're increasing that non-exercise activity thermogenesis. Cooking, cleaning, singing actually goes into it as well. So the more things that you're doing outside of just sitting around doing nothing, the better it's going to be. And this is the greatest variable when it comes to your energy expenditure. Between 150 to 500 calories per day comes from this non-energy activity thermogenesis. One way to really make sure that you're optimizing that is by step counts. The more steps that you have, the more likely you're going to increase your non-exercise activity thermogenesis. Your goal is obviously 10,000 steps per day if you can manage that. All right, let's get through the medications. I have a lot of data on these slides, so they're very heavy with data. I'm probably not going to go into detail about all of these as much, just so we can keep on our target for time. But indications are for adults with obesity with a BMI over 30, or if they have a BMI over 27 with at least one weight-related complication. And again, this is in addition to lifestyle modifications. These medications cause you to lose weight. They don't cause you to specifically lose fat mass, okay? So when you lose weight, you lose lean muscle mass as well. If you're exercising and you're following the right diet, you're going to limit how much of that lean muscle mass you're losing, which is why this is so important that patients follow the lifestyle modifications as well. These are all the medications that we're going to go through, and we'll try to go through them really quickly. Phentermine is probably the first line of therapy for most people. It's only approved for 12 weeks in duration. It's a sympathetic amine, so it's going to have a lot of those stimulatory effects on the body. So if you look down at the side effects, it's going to be a lot of those stimulatory side effects, so like insomnia, tremors, abnormal heart rate, high blood pressure, etc. There's multiple different doses, but really in the US, you're looking at the 18.75 formulation or the 37.5 milligram formulation. I personally just started at 37.5. I don't think there's a reason to start at a lower dose. If they don't tolerate it, then you can go down to the lower dose, right, if they want to continue to take it. It's only approved for 12 weeks. However, it is used off-label by a lot of obesity medicine specialists indefinitely. So just because of that indication for 12 weeks doesn't mean you only have to use it for 12 weeks. Contraindication, so hypersensitivity. Pregnancy and nursing is going to be a contraindication for all of these medications. Okay, so I'm not going to touch on that on every slide. And then cardiovascular disease is the big one. History of coronary artery disease, hypertension, et cetera, et cetera. So when I'm talking to patients, if they have any whiff of cardiovascular disease, I skip over all phentermine-containing medications and just go to the next line of therapy. Hypothyroidism, glaucoma, agitated states, history of drug use, et cetera. Okay? Outcomes are pretty okay. They're middle of the road. So you can see in this one study, 205 patients, 3.63% total body weight loss. Down here at the bottom, these two 5% total body weight loss and 10% total body weight loss. This is your relative risk or your odds risk or odds rate compared to placebo. So you're 4.12 times more likely to get 5% weight loss over placebo, right? You're 5.1 times more likely to get 10% weight loss over placebo. Does that make sense to everyone? Okay. So it's not bad. It's not great. Our kind of goal that we're looking for is about 5% weight loss with any of these medications, okay? So phentermine topiramate, this is also called Casimia, so that's the brand name for this one. This is a combination of phentermine and topiramate, which is an anti-epileptic, anti-seizure medication. It enhances GABA within the brain. So it comes in it comes in one pill, basically, one dose to start with. You're going to use that dose for 2 weeks, go to the next dose, so the 7.546. If patients hit that 5% weight loss with that second dose, you're good. You can continue that one indefinitely. If they don't and they're tolerating the medication, then you go to the titration dose. So you go to the 11.25 to the 69, and then after another 2 weeks, you go to the max dose. So those two middle doses, the 3.75 and the 11.25 doses, those are kind of like a bridge to the doses that you want to get to. Side effects are going to be similar to just phentermine by itself, with the addition of you're going to have dysgeusia, which is this abnormal like metallic taste in your mouth, as well as paresthesias, because that's from the topiramate. This is a different meta-analysis, different type of meta-analysis that was done. You can see outcomes are actually pretty decent. So 8.5% total body weight loss at 1 week, and then 5% total body weight loss. 72% of people taking it achieved at least 5% weight loss. 49.7, almost half of patients achieved 10% weight loss at 1 year, okay? Remember these numbers, because I want you to compare this to some of the other medications we're going to talk to, okay? Contrave. So this is actually a really good medication for certain people, and for other people it may not be good. So bupropion, naltrexone, it's a combination of an opioid antagonist as well as an antidepressant, which is bupropion. The titration table is there in the second level, so you're going to take 1 pill in the morning, then 1 pill BID, then 2 pills in the morning, 1 in the evening, and then 2 pills BID. And every week you're going to go up on the dose of that till you hit that 2 pills BID dose. Big contraindications for this is uncontrolled hypertension, because bupropion can cause hypertension, and then anything that's going to cause or potentially cause seizures, because bupropion actually decreases the seizure threshold. If you've ever written for Wellbutrin, you know that you shouldn't use it in people who have a history of seizure disorders, right? So anything that might increase your risk for seizure disorders, like alcohol use, opioid use, withdrawal, anorexia, those are things you want to look for, and then you wouldn't use this medication. Outcomes from this, they're okay, right? So remember what I just showed you on the phentermine topiramate, the Casimia one. Obviously not as good as that. I will tell you from my personal experience though, some people respond really well to this. Other people don't respond as well, okay? So just because the outcomes in these meta-analyses are not as good doesn't mean it might not work for everyone. This is still a medication to try. This is a different meta-analysis, and you can see at 1 year, 6% total body weight loss, 52